I'm going to talk about is just the barrier itself, because this will help you in understanding nephritic and nephrotic syndrome. So the first page I'm going to use is this one. Okay. Now understand, we're making an Oreo. Okay, we have to make an Oreo, right? The Oreo, the first biscuit layer, the middle cream layer, and then the bottom biscuit layer, right? That's how we're going to understand what are the different layers of that glomerular basement membrane, and all the 3 layers. Okay. First thing is you have to understand there's 2 cell layers, 2 biscuits. Okay. First biscuit is this. This is the vascular structure. The vascular structure has its own endothelial cells, right? So endothelial cells are the first layer, first biscuit. Okay.
Got it.
The bottom biscuit is the podocytes. Podocytes are specialized cells. They have a lot of negative proteins in them, right? Negatively charged proteins, and they repel a lot of amino acids, proteins, etc. Right?
Okay.
And they help in filtration. So they bind together like this. They call them fenestrations, right? Those fenestrations help in filtration, right? So that is the bottom layer, right? So we made the 2 biscuits. Now we have to understand what's happening. You see, cells need a basement membrane where they can sit on, right? So the basement membranes where these 2 basically sit on is this thing right here. That's the cream part.
Okay.
Okay. So 2 cell layers and then the cream part, which is called the membrane, right? So when they say glomerular basement membrane, this is actually what they're talking about, GBM. Okay. Now understand the other couple of layers that you have once you go inside the glomerulus, you see the packing cells, right? Every organ has its packing cells, right? They call it the interstitium, right? So the interstitium of the glomerulus is this area right here, right? And this is filled with mesangial cells. Okay, this is called mesangial cells, right? So if they ever talk about mesangial expansion, mesangial hypertrophy, those are the things that's going to happen there, right? Now let's understand the deposits and the stuff that happen with nephrotic syndrome. When we look at it, we'll look at it in detail, but understand what's happening. Okay, when they say subendothelial, okay, this is considered endothelial because of endothelium cells, right? Endothelial cells that line the vascular structures. So subendothelial cells mean between the glomerular basement membrane and the endothelium cells themselves. Okay. So subendothelial. Intramembranous makes sense. It's within that cream layer. Okay. And then subepithelial means right underneath the podocytes. Okay.
Right underneath the podocytes. Got it.
So we need to understand subepithelial. We need to picture it: subepithelial, subendothelial, intramembranous. Right. So whenever they talk about which one's which, we can imagine it. Okay. So that's the first thing, right? Now we can go into a couple more points. Filtration and all that, right? So this is the barrier. You can revise this: negative charge proteins, molecules, and all of that. Okay, right? So these are what is contained within those cells. Okay, and each of this is one line of protein, and then there's another line of protein, and then they have this something called chondroitin sulfate or creatinine sulfate. Okay, now these hold up a lot of water, and they have a lot of negative charge, right? They hold the negative charge allows those podocytes to repel proteins. That's why you don't get albumin in the thing. That's why you don't get RBCs in the urine. Okay. So, and also all of these are located into your joint fluid. They're located in the basement membrane. They help in, whenever have you heard of hyaluronic acid for your skin and stuff?
Yeah.
Right? So this is what they basically are the family from. Okay. So they help in making and holding water and in the skin, the basement membrane, wherever. Right. So this is important. We'll go over this if we cover in biochemistry, but this is what they're holding. Okay. All right. So we understood this. We understood the microscopic structure. You see, this is subendothelial, intramembranous, and then subepithelial deposit. Right. These 3 structures are the Oreo. Okay, good. Hypercollagen, heparin sulfate, we just discussed this. This is what they're talking about, okay? This is the GAG. Heparin sulfate is a type of glucosaminoglycan. Heparin sulfate. Okay. All right, moving on. Now, let's talk about all these different, pressures and the clearance and stuff like that, because a lot of people get confused with creatinine versus para-aminohippuric acid or inulin and all of that, okay? So let's figure this out, right? Now, this formula that you see here, right? This formula that you see here, it's universal to even pharmacology, but if you apply it to just the renal part of things, you can use it wherever. Okay. So understand it like this. This is called the dilution formula, right? You see C1V1 is equal to C2V2, right? You don't have to memorize it, but understand what's going on here. Okay. You start with some sort of concentration and with some sort of volume, right? But then you add something else into it, and then you get the new concentration multiplied by the new volume, right?
Yeah.
The thing is, this whole multiplication should equal each other. You cannot add or destroy matter, right? Whatever you've have in that beaker or that solution should equal each other. Okay. This is basically what is happening when we talk about clearance. Okay. Now understand that volume is one thing, but if the volume flows, that is called rate of volume, right? Volume flow, right? Rate of flow.
Yeah.
That is basically what clearance is. Volume per hour. right? You have to understand that. If I just divide this whole equation divided by hour, right? Divided by hour, because volume flows in whatever hour, right? Then this will become clearance. Volume per hour becomes clearance. Does that math make sense?
Yeah.
Right. So that is what clearance is, volume per hour. Okay. Now we take a look at this. So if I just bring this denominator and cross multiply, so what do I get? I get CX PX, right, equal to U times V, right? VU. Let's do that.
I see.
Right. So what is happening is, compared to that formula, this is the concentration of plasma. This is the volume of plasma going into your glomerulus. Same thing that you see here. Don't get confused between the C's. C here represents the concentration. In our equation, it's plasma concentration. Right?
Okay.
And what did I say? If you divide volume by hour, you get clearance. That's what the denotion is. Okay.
You divide it by hour.
Yeah, it's the same formula. Okay. And then you look at what's happening here. Volume of urine multiplied by concentration of urine. Sorry. U is urine concentration. Okay. So concentration of urine multiplied by volume of urine, concentration of plasma multiplied by volume of plasma. Does this make sense?
Yeah.
Right. So it's the same. C1V1 is equal to C2V2, and that's how you remember what's going on. Right. So if they ever ask for renal clearance will equal this. Right. C is equal to U times V. That means urine concentration, volume of urine divided by plasma concentration. Okay. So it makes intuitive sense now. How did this thing came up? Right.
Yeah.
So that will help you remember it, right? And then they've given you all the things. As I said, you see, volume divided by time unit, right? We took per hour, but it could be per minute as well, right? This is both concentration, so milligrams per milliliter, and then urine flow rate, of course, because it's again flow, right? Flow rate, right? So volume divided by per minute. Right. Okay. The thing is, if you even forget like the formulas, sometimes you can make sense of this values and you can get it. Because if you just remember, clearance is supposed to be volume per unit time, right? I can multiply it in some way and get this, right? Because all of these will cancel out, and then I'll get the ml per minute. Okay.
Yeah, I think I did those for one of the questions.
Right. So you will see this. Okay. All right. Now understand the next formula. Okay. Clearance or any sort of filtration, you see, clearance is equal to filtration, how much of the thing you're filtering, minus how much, plus how much you're secreting, minus how much you are absorbing. I think tubular secretion, filtration, and then reabsorption. Okay. So how much you're filtering plus how much you're secreting into something minus all of this by how much you're reabsorbing. Okay. This is what will make the urine, basically. Does this make sense to you?
Yeah.
Right. Now, what happens if you have, let's say, clearance less than GFR, right? If clearance is less than GFR, that means that there is a lot of things being reabsorbed, right? Clearance means how much of fluid is going into the urine, right? That's what clearance means. So if you don't have enough urine, but you have a lot of GFR, that's what this denotes, right? That means you're reabsorbing everything. Does that make sense?
Yeah.
Okay. If clearance is greater than GFR, means you're secreting a lot of things into it, right? Understand it like this: there's a lot of urine being made, but there's not enough GFR coming in. So what are you doing? You're throwing some stuff actively into the nephron, and that is going into the urine. Does that make sense? Okay. Clearance, if it's equal to GFR, that means all of this has gone away, no net secretion or reabsorption, right? And clearance is equal to the GFR.
Equal balance. Okay.
Yeah. So you can use this formula wherever. For example, let's do this again, right? Clearance is less than GFR, so net tubular absorption is happening. So basically, this and this is cancelled, and you get this. Okay. If you cancel this and this, you see secretion is equal to the clearance, right? And if you cancel this and this, you see filtration is equal to clearance, right? Now the thing is, renal clearance, you can find it out, but the thing is, you have to find out what is being cleared, right? What is being secreted? What is being reabsorbed? So what we did was we came up with standard ways of investigating this, right? So the three substances that you're supposed to remember, one is creatinine, right? Next is PAH, and next one is inulin, right? And they've mentioned inulin right here, right? Now we just have to understand what is happening with all three of them, right? Because this will help me figure out my clearance. It could also help me figure out my GFR, okay? Which is important in this patient, right? Now, understand it like this. First of all, creatinine. Creatinine is the most abundant substance naturally produced by your body. Creatinine undergoes a lot of, you see, it's an approximate measure of GFR because it's moderately secreted, right? If something is completely filtered and it's a little bit of secretion, you see that's an accurate measurement of what? You see, I'm going to draw, or I'm just going to draw we're going to use this GFR here, right? So
Okay.
as I said, here is creatinine coming in, okay? Here's creatinine coming in, and only a little bit of it is secreted over here. So that means it's an accurate measurement of GFR. Does that make sense?
Okay.
So
Because
that's why I use creatinine when it comes to GFR measurement, right? It's readily abundant and it's indicative of the glomerular basement membrane and functioning of the glomerulus, right? Because most of it, about 90% of it, is filtered, right? And only some of it is secreted in, right?
Yeah.
Now, we came up with something called inulin, right? If you see inulin and inulin's properties, you see, is freely filtered and is neither reabsorbed nor secreted, which means both of these, this one and this one, is cancelled basically, right? Inulin can only be filtered, which means it's an even more accurate. You see, if I go into this diagram, inulin, 100% filtration, right? And 100% filtration means a very accurate prediction of GFR. Does that make sense? Okay. So inulin, very, very accurate prediction of GFR, but I have to inject it into the person, I have to wait for them to filter it. Creatinine is just readily available.
Okay.
All right. Next comes understanding the formula for inulin, right? So you see, we already discussed this. C is equal to U times V divided by P, right? So it's the same thing. But why, if I do this, right? If I do this, clearance of inulin is actually just GFR. You understand?
Yeah.
Because inulin is 100% filtered, so I know exactly what the GFR is. This makes sense?
Yeah.
Right. All it's doing is it's only going to do subtraction. Basically, what we have to find is the gradient of pressure, right? So we're going to subtract gradient of the static pressure and the gradient of oncotic pressure, because that's how I will know how much fluid, right, or how much force is being experienced by the fluid. That's it, right? So what you do is, you see, Bowman space. Okay, so what you do is, now we're just going to account for static, right? Static out here, from here, right? For example, let me do this. This static pressure is pushing outward, right? This static pressure is pushing outward, right? So I have to subtract both of these, right? So this is called PBS because of Bowman space, and this is called PGC because of glomerular capillary. Okay, so what do I need to do? PGC minus PBS, right? Usually this one is going to be greater. Why? Because it's it's controlled by the arterial system, by your heart, right? So this will dominate, and you have net flow going this way. Does that make sense?
Yeah.
Right. You see, I've thickened it. You understand? PGC is greater than PBS, right? So that's why they did the subtraction over here. Make sense?
Yeah.
Right. Now you look at the oncotic pressure now, right? I'm going to do it over here. You see, oncotic pressure here is pulling water into the capillaries, right? And it's very, very high, so I'm thickening it. Okay.
Oncotic. Yeah.
Right. And this one, the oncotic pressure here is pulling away from this thing. Right. So oncotic, and they say, like pi GC and pi BS. Okay. So if I subtract these two, I will get a net resultant that will give me possibly to this place, right? So the net resultant that you see here, I don't know if I can change my color. But you see, because always hydrostatic pressure will always be higher than the net, oncotic pressure. That's why the fluid moves out.
Got it.
Okay. So we calculated these four pressures. We took the gradient of both of them, and then we subtracted them both again. So that's why you see, right? You see this, the negative. Take the gradient of this, take the gradient of this, and then you subtract them, and you get net pressure pushing outward.
Okay.
Now, the pressure isn't enough. You have to multiply it, but with some constant, right? Filtration coefficient. They will usually give this to you if they want you to calculate it. But that's about it.
Okay.
Right? This principle applies in every tissue. When they talk about exudative effusion or transudative effusion, all of this remains the same. Okay. If they ever talk about, for example, let's just discuss a couple of things. If there is hypertension, which pressure will increase?
Hypertension. Increase hydrostatic.
Right, hydrostatic, right? Within the capillary, right? So the PGC, glomerular capillaries, will increase. Okay, let's say someone has nephrotic syndrome. What's going to happen to all these pressures?
You would have.
So what's happening in nephrotic? You just tell me first.
I think the one affected would be oncotic pressure,
Right. Where? How will it be affected?
but it would be affected by lowering oncotic pressure.
Lowering which one? You have to tell me that.
Oncotic pressure.
But which one? Is it the glomerular capillary or this one?
Not the glomerular capillary, the other one.
So this one will be low.
Yeah, because that way, when everything pass by.
Right. So understand it like this. Because you're damaging the podocytes, you're leaking more and more protein into the Bowman space.
Uh-huh.
And what did I say protein does? It attracts water, causes oncotic pressure to increase, right? So this will end up decreasing, this will end up increasing. Does that make sense?
Okay, can you say that one more time?
So protein here is decreasing, right?
Mm-hmm.
Protein here is increasing
Mm-hmm.
because of nephrotic syndrome, right? So if protein increases here, this will have more oncotic pressure.
Because of the damaged podocytes.
Exactly. You understand now?
Yeah.
Yeah. So that's how they will confuse you. Which one's increasing hydrostatic, which one's increasing oncotic, right? Same thing happens in NSAIDs, right? If albumin is in the acidic fluid, they can ask you about oncotic pressure and stuff like that, right? So understand it right now. Okay, it's not that hard. It's just outward pressure minus inward pressure, and then the net flow of them. Okay,
Got it. Yeah.
but keep looking at it. It'll be easier and easier as you look at it. Okay, so we understood inulin, we understood the creatinine used for GFR purposes, right? But there's this thing called renal plasma flow. Renal plasma flow means in the entire kidney, right? In the entire kidney, how much of that kidney is receiving how much plasma, right? And what's the flow of that plasma, right? Now,
Yeah.
in order to do that, I need something that is completely excreted, because only then can I be able to figure out how much is going in the system and how much is going out, right? If I figure out how much is going out, I will definitely know how much is going in. Does that make sense?
Mhm.
Right? The only thing that they found that is completely 100% excreted, right, is called
Mhm.
PAH, right? Para-aminohippuric acid,
Okay.
right? How does pH accomplish this? You see, within the diagram, you'll see 20% is filtered, but then 80% is secreted, which means 100% has to be excreted.
Yeah.
No reabsorption, right? So if I go back to this formula here, there's no reabsorption. This plus this will equal para-aminohippuric acid.
Okay.
So this is what happens if I calculate the clearance of PAH, right? If I calculate the clearance of PAH with the same formula, UV by P, I get the clearance of PAH. But this basically says I have my renal plasma flow.
Okay.
Right? So GFR is inulin, renal plasma flow and renal blood flow is pH, and then GFR, with a little bit, inaccurate, you use creatinine. I've just mentioned that here.
Mhm.
Right? Now, sometimes they may ask you, see, renal plasma flow does not account for the hematocrit, right? It just accounts for how much fluid is going in. So what do you do? You just have to divide it with 1 minus hematocrit, right? So if you divide it, you get the whole blood, not just the plasma,
Okay.
right? And this formula actually comes back up here because of this. You see, plasma volume is equal to total blood volume minus hematocrit, right? And the thing is, to better understand it, here's what I do. I multiply it, okay? Here is TBV minus, I'm just multiplying it this, right? So TBV times hematocrit. That one is confusing. You know why? Because it doesn't make intuitive sense. You see, what I'm doing is total blood volume. I'm taking the total blood, subtracting the hematocrit from it, percentage of hematocrit from it, and what am I going to receive? Plasma. Does this formula make sense?
Yeah.
Yeah. So if I
Yeah.
just take it and divide it here, what am I going to get? Total blood volume or renal blood flow, right?
Got it.
So
Got it.
this
Got it.
becomes renal plasma flow. This becomes renal blood flow,
Okay.
right? So that's how they do it, right? So always just multiply it. You'll understand what you're doing. You're taking the whole complete thing, subtracting amount of hematocrit from it, and you're going to get your plasma volume. Or you divide it by per unit minute, per unit time, and you get renal plasma flow versus renal blood flow. That's what it is.
Okay.
All right. So we understood all of that stuff. We're good. No problem.
Yeah.
All right. Now moving forward, filtration, right? The thing is, what they did is they take both of these GFR and how much the renal system is receiving, and they came up with filtration fraction. So all that we did here, right? GFR with inulin, RPF with pH. If you really want accurate measurements, you get the filtration fraction.
Okay.
Normally, it's supposed to be 20%, right? So I filter 20% of how much plasma is coming in. Make sense of it, right? I filter 20% of whatever the renal system receives. Okay,
Okay.
that's what it means. Now, because you see it's a fraction, right? So this is also volume per minute. This is also volume per minute. That's why this does not have a unit. Okay. If I need to calculate how much of actual like concentration is actually going through that system, they came up with filtered load. You see the value, concentration per minute, right? Milligram per minute. All they did was, you see, they took the GFR, multiplied with the plasma concentration of whatever substance. Let's say I gave them drug A, right? Drug A leads to plasma concentration of 500 mg ml. It should, I don't think it should be that much, but 500 mg ml, right? And then I calculated that GFR is, typical GFR is how much? I think it's like, 100 ml per minute, right? So all I do is just multiply them. So 100 ml per minute times 500 milligrams. So 50,000 milligrams per minute. Does that make sense?
Yeah.
All right. Now moving forward, the efferent and afferent arterial problem, right? Efferent. Okay. Afferent means coming in. Prostaglandins control afferent.
Okay.
And what did I say prostaglandins do? They dilate. They allow the smooth muscles to contract and they open up that area. Okay. If they open up that area, you see what's happening. The entire kidney will start to receive more plasma. The entire nephron will start to receive more GFR, right? And if I divide both of them, there's not going to be any change in filtration fraction. Does that make sense?
Yeah.
Okay. Now, how are prostaglandins inhibited? By NSAIDs, which means low GFR for a person who is on NSAIDs, low renal plasma flow for a person who is on NSAIDs, and then no change in filtration fraction. Does these two make sense?
Yeah.
So when they say NSAID-induced nephropathy, NSAID-induced nephrotoxicity, this is what they're talking about, right? You're not allowing your GFR, your glomerulus, to receive blood. That's it. Okay? So that's how NSAIDs damage your kidneys, right? Then we come into, and they've done the whole thing again here. You can take a look at this diagram. Whatever I did in the previous diagram is already done here. So then you come to the efferent arteriole. The thing that controls this is angiotensin II, part of RAS system, right? So if RAS system is active, this is contracted, which means, you see, if I block this right here, everything is going to go into this, right? If something is blocked downstream, then everything upstream will go into a different space. Isn't that correct? Right? So what is happening? GFR is increasing. GFR is increasing, right? Because everything is being forced to go over here instead of over here, right?
If it's constricted.
Right. If it's constricted, GFR will increase. Exactly what the RAS system wants. You understand? Now, but because you've caused this block, will you allow the entire kidney to receive enough blood? No. So renal plasma flow decreases. That's the only nuance. So whenever there's a RAS system that is active, GFR will increase, forcing blood into whatever blood you have, forcing it into the glomerulus, but the renal plasma flow, overall blood that the kidney receives, decreases.
Got it.
And if you divide these two, what's going to happen? Filtration fraction has increased. What do ACE inhibitors do? Opposite. ACE inhibitors decrease GFR, right?
By dilating.
Right, and they increase RPF.
Got it.
They're dilating. Yeah. All right. So now we just look at all these. So afferent arterial constriction. Imagine it in your head. You're constricting what? This thing, right? You're constricting this, right? So you're not allowing GFR to happen. You're not allowing RPF to happen, and both of them are low. That means filtration fraction is same. Does this make sense?
Yeah.
Right. If this is contracted now, what's going to happen? GFR will increase, RPF will decrease. That makes sense?
Yeah.
Right. And then because of the division, you see the increase. If you increase plasma protein concentration, right? Let's say in what condition you may see high protein concentration. Can you think of some? Hematologic malignancy, leukemia, right? Multiple myeloma, right? In all of those, you're increasing protein volume, right? If you increase plasma protein concentration, well, oncotic pressure increases. In what? In the glomerular capillary, right? So will you give more blood into the filtration? No, you won't. Does that make sense?
Yeah.
Right? So you've just made a correlation. Leukemia, high load of leukemia can lead to renal damage. Make sense now?
Yeah.
All right, good. Low protein concentration. We discussed this already. Nephrotic syndrome is the most common. It can be cirrhosis. It can be, liver failure, whatever, right? Malnutrition. GFR will end up increasing because oncotic pressure, the glomerular capillary oncotic pressure has decreased. So it's not holding on to that water too much. It's letting it go.
Okay.
Yeah. If you constrict the ureter, right? Ureter is downstream, right? So it's somewhere over here, right? You constricted this guy. Now, what's going to happen to the GFR? You see, eventually, all of that the urine will, exert a force back here. You understand? So what did you just increase? You increase the hydrostatic pressure of this space right here, the PBS. That's what you just increased.
Okay.
Right? I'll give you a couple more examples. If you have a stone, right? Stone has blocked the ureter, right? All that back pressure will go and it will not allow filtration to happen because you increase the hydrostatic pressure that is experienced over here.
Okay.
Yeah. Another one, it could be blockage. It could be that posterior urethral valve, right? That we just saw. If you have that, the urine will be blocked from flowing, and then all that pressure will be exerted, not allowing any filtration to happen. That is what post-renal injury, right? Post-renal acute kidney injury. So I'm discussing all the post-renal stuff with you, right? Pre-renal would be there's no thing coming on over here, right? But post-renal is this. So this makes sense. This part makes sense, right? And then dehydration, we understand, is just not enough fluid coming in.
Yes.
All right. So we understood all that. Now, next thing is glucose clearance and secretion of like sodium absorption stuff. Okay. Same thing that we did with inulin, same thing that we did with CR, creatinine and stuff like that. Same thing we're going to do with sodium. Okay. So what you do is you have to, in order to calculate how much sodium you're actually absorbing, you have to divide it and find out sodium excreted. That means how much is in the urine divided by sodium filtered. That means how much actually came in, right? That's how you get the fraction. So what you end up doing is you expand this formula. Sodium excreted is equal to clearance of sodium. So you see VUNA. Sodium excreted is this, right?
That's the cleanest. Yeah.
Right. And sodium filtered is this thing right here, which is just creatinine. Right. So what they did is they just plugged it in, and you get the final expression, which is this. You don't need to remember that. All you need to remember is clearance of sodium divided by GFR.
Okay.
Yeah. If you can do that, everything is easy. And it makes intuitive sense, right? Because we've learned all the clearance things now. You just have to divide it by how much is filtered, which is GFR.
Got it.
Okay. Now, glucose clearance is the same thing, right? The formula and everything will be the same. But what we see is glucose clearance is kind of different from the other parts of it. Okay. Each part of the nephron has some sort of a behavior, right? So we have to understand that behavior, right? First thing is SGLT2. We saw it in the endocrine section, right?
Yeah.
Those are the things that are responsible for glucose, absorption, right? So that's the first thing. Now, understand it like this. If the plasma glucose, this is important, right? Plasma glucose is being measured against glucose transport, right? What they say is, as you keep increasing plasma glucose, let's say someone is actually, diabetic, right?
Yeah.
Until a certain point, everything will be absorbed, right? After a certain point, everything will be excreted.
Yep.
Okay.
Got it.
What is that certain point? That is this renal threshold, right?
Okay.
So at renal threshold, everything is, it can be absorbed, it can be, processed. But after this, everything will be excreted, right? You see that excreted graph just picks up so much,
Yeah.
right? And then you see what's happening here. You see, in adults, at plasma glucose of 200, glucosuria begins. And if you don't know this, you see this is giving you in milligrams per deciliter, right? If you divide 200 by 18, no, 18 is the molecular weight of glucose.
Okay.
So if you divide it, you get moles per liter or millimoles per liter. Have you seen that? This being mentioned, right? So you get millimoles per liter, right? So sometimes if you forget if it's 11 per deciliter or something, the level of, if you have fasting or random blood glucose greater than 11, you have straight diabetes, by the way. Okay. So correlate that with the renal sort of threshold. Okay. So greater than 11 millimoles per liter, you're going to get glucosuria and you're also diagnosed with diabetes. Again, see, this is milligrams per deciliter, right? As I said, 200 or above. We just saw it. Glucosuria begins at 200. Okay. You are at 200, you're going to get the thing, right? And if you need to convert it to millimoles, because sometimes it's confusing, you just divide it by 18. Yeah. All right. So we understood this. Now, typically, you see the rate of transport, right? Typically is 375 milligrams per minute, right? So this is the actual rate, or this is the actual rate where the entire absorption actually happens. Okay. This is the maximal rate that it will go. After this, it's just going to be, one constant line. So what ends up happening is, you see, glucose is being reabsorbed, right? But as soon as it tries to reach this area, right, this thing, once it actually reaches it, it undergoes this constant, reabsorption, because that's the maximal rate, right?
Okay.
What it shows is, you see, it's not an acute thing like this, right? This is called the splay phenomena, right? And it's nothing crazy. It's all that it's doing is, this says that, naturally you're not going to go this acutely into it. You're going to ease into that saturation state. That's all.
Okay.
Okay. You cannot just go from on and off stage in a biological system, right? So that's what's happening here, right? So it slowly goes towards reabsorb, right? So we understand the excreted and the reabsorbed, right?
Yeah.
And then this is the constant filtration that is happening for glucose itself.
Okay.
All right, so we understood this. All right. So lastly, what we're going to do is we're going to go through how parts of the nephron work, because all of this is responsible and important for diuretics, right?
Okay.
So let's finish this one by one. I'm going to start from the back. We're going to start from collecting tubules, because this is the most important part, right? When I was doing aldosterone, did I go into this or no?
Yes.
A little bit, right?
A little bit, yeah.
So quick revision, aldosterone, or even the well, let's just do aldosterone first. Aldosterone goes in two cells, principal, alpha intercalated, right? Is what does it lead to in principal cells? What does it lead to alpha intercalated? Sometimes they do ask that.
Okay.
So in principal cells, aldosterone leads to first potassium excretion via potassium transporters, right? Sodium absorption via sodium transporters. These are called ENaC channels. You heard of them? ENaC, right? This is the special type of thing that is only on the principal cells, not in the alpha intercalated. So that's an important point right here.
Okay.
Right. And then, yeah, and these two are the main functions. Okay. And then, of course, because sodium is coming in and potassium is going out, this one will be stimulated to move forward. Right. You see, sodium coming in, so I'm going to put it into my bloodstream. And if potassium is going out, I need to replace it. I'm going to get it from the bloodstream.
Got it.
Yeah. There's also the ADH. ADH also works on principal cells along with aldosterone. It leads to H2O coming in, which is aquaporin, right? It's mentioned here. And a urea transporter. I think I mentioned this. They've put it into the new first aid, but always remember this.
Okay.
Urea comes in because of ADH.
Got it.
Within the the alpha intercalated cells, there's no sodium reabsorption here, but there is hydrogen excretion going on over here. Right? Again, there is some amount of potassium taken in, but who predominates? It's this one that predominates. So don't ever be confused about, well, potassium is coming in. No, aldosterone has net potassium excretion.
Okay.
And all the alpha intercalated cells is doing is pushing out hydrogen. You see hydrogen is coming out. Right? Where does this hydrogen come from? It comes from water. Right? Water and carbon dioxide. H2O plus CO2.
Okay.
Right? And then who breaks this down? Which enzyme helps in processing of this? H2O and CO2? The most important ones. So 2 is located in the cytosol, 4 is located in the membrane, and 6 is located in the saliva and the milk. If you can, note it down somewhere, it's fine. But yeah, 2 and 4 is inhibited by carbonic anhydrase inhibitors. That's, I think, if I remember correctly. Yeah, you see, this is what we're talking about. Right, carbonic anhydrase 2, which is inside the cells, right? We just saw it. This is taking the H2O and CO2 and converting it, right? And then carbonic anhydrase 4, which is on the plasma membranes. This is in the outside, and it's converting it back into H2 and CO2. So 2 and 4 are the most important ones. Okay. So carbonic anhydrase again is being used, and you get bicarbonate in the plasma here, right? So again, just to summarize it, hypokalemic metabolic alkalosis, aldosterone. Remember?
Yes.
Hypernatremic hypokalemic metabolic alkalosis, and you see the mechanism now. This makes sense?
Yeah.
All right, good. So, and then we have also known that bicarbonate and chloride have a love-hate relationship. They're opposite, right? So they go into the exchanger at the beta intercalated cells. If you can remember that, that's great. But just remember at least that they're opposite to each other, right?
Chloride and bicarbonate.
Yeah, chloride and bicarbonate, yes. Okay. So we understand this part. Let's go into the DCT now. DCT is where the thiazides work. Thiazides work on the sodium chloride channels. Both of them are coming in. Okay. Both of them are coming in, and they're taken up again. Sodium is taken up by this thing, and then there is a calcium diffusion channel, which naturally just takes in the chloride diffusion channel, which just naturally takes this up. Okay. The most important part, because they will ask you questions like, which diuretic is most suited for an osteoporotic patient? What's your answer?
Thiazides.
thiazides. Okay. What they also lead to is hyperuricemia. Thiazides lead to hyperuricemia. So if there is a drug that is contraindicated in gout people, thiazides.
Thiazides.
Right.
I
So
saw that in cardio.
yeah, yeah. See, thiazides are inhibiting it. So both of these are going into the urine. Right. If sodium is not there, what will this thing do? It will pump sodium in, and what will it do in exchange? It will take calcium inside the cell. Does that make more sense?
Yeah.
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 Sodium and this thing are going into the urine. This will pump sodium in. It'll take calcium in.
Got it.
In the blood. Okay. Two, thick ascending limb. How do furosemides work? Sodium, potassium, and 2 chlorides. Right. Massive amounts of movements of ions. That's why they say furosemide is such a good diuretic. Right. All of this is going to go into the urine. You understand? All they've done, in these diagrams is when it comes to magnesium and calcium is how can they be absorbed. So magnesium and calcium can be absorbed in the thick ascending limb via. Yeah, this is paracellular. So this is what they say, paracellular, right?
Okay.
This one is transcellular. It means it's going through the cell.
Okay.
Okay. So transcellularly, magnesium and calcium can be absorbed through this mechanism in DCT. When it comes to TAL, it's usually paracellular. Usually this isn't very good, right? It's not very great, but it can be achieved.
Okay.
And then the last one is everything is going to be absorbed by the PCT, glucose, sodium, everything is going to be absorbed. Amino acids, everything, right?
Okay.
Even a lot of bicarbonate is going to be absorbed.
Okay.
Right? You see, how does carbonic anhydrase inhibitor work? Acetazolamide, right? How does it work? It doesn't allow this exchange to take place, so bicarbonate is gone into the urine.
Okay.
Does that make sense? Bicarbonate is gone into the urine. So what does it lead to inside the person? It leads to metabolic acidosis. Does that make sense?
Yeah. Yeah.
Okay. So if I go into, just to revise the diuretics for a second, you see, one of the uses for acetazolamide is metabolic alkalosis. Why? Because the carbonic anhydrase inhibitor will get rid of the bicarbonate. Right? It'll get rid of the bicarbonate. It will allow you to reduce your alkalosis. Okay. Same with altitude sickness. You see, you're breathing out a lot of CO2 when you go up. In altitude, you breathe out a lot of CO2. You're getting alkalotic because you have respiratory alkalosis. How does acetazolamide help? It excretes all the bicarbonate.
Okay.
Right? But it leads you to have the venotubular acidosis or just metabolic acidosis. Just remember that. Metabolic acidosis.
Okay.
Right? You see, this one also leads to hypokalemia. And the reason for all of that is because these drugs, they're not allowing the PCT to absorb properly. So just going back to this place. Yeah. Again, it's not allowing your, exchangers to work properly. Okay. So potassium is being lost. Sodium is, also not working too much, right? So it's because it is slightly a diuretic. And then you're also losing bicarbonate. That's the principle of acetazolamide.
Got it.
Yeah. This diagram right here. This one. Okay.
Okay.
Now, okay. So distance along, percentage distance along the proximal tubule length. So as you see, most of the glucose amino acids bicarbonate is very, very easily absorbed and very early absorbed. That's what this means. Okay. Now I'll explain the whole ratio. What you're seeing here is how much of it is in the tubule. So if I go and use this diagram, you see this diagram, right? How much of it is in here versus how much is it in here? That's what they're comparing. Okay. So if you come back here, how much of it is in the tubules versus how much of it has gone into your plasma, right?
Yeah.
If this is high, this whole value will be low, right? Right? If everything is being absorbed into your plasma, the ratio will be low, isn't it?
Yeah.
Right? So if everything is being very, very easily absorbed, then T by P is supposed to be less than 1, which makes sense because you're supposed to absorb everything that is precious. It just means that the PCT prefers to absorb these things very, very, actively.
Okay.
Yeah. So all the ratios of these guys are less than 1. That's why they're on the bottom half of the graph.
Got it. Bicarbonate, amino acids, and glucose.
Yeah. Okay. How much does the PCT prefer sodium? Sodium is going to be absorbed continuously throughout at the rate of 1. Okay. So the level of tubular fluid and the plasma fluid level will always be equal, and they will probably be equally absorbed in the entire length of the PCT. That's why you see osmolarity and sodium will always be equal.
Okay.
Yeah. Potassium is just a little bit above that. Okay. And then as you go up, you see now the PCT doesn't prefer this as much. That's what is happening, right? PCT doesn't prefer chloride as much, doesn't prefer urea as much, right? So more of it is staying within the tubules, right? And as you go up, you see our three guys, right? Inulin and creatinine, they're close to each other. They're not being reabsorbed too much. PAH is not completely reabsorbed. Why? Because most of it is secreted.
Okay.
Right? So this is the entire explanation of this diagram.
Got it.